Hello, everybody, and welcome back to Burning Migraine Questions, our little video series where we discuss all things related to chronic headaches, specifically as they relate to neuralgia of various kinds and the surgical intervention thereof. We took a little bit of a hiatus for many reasons as of last year. But we're now back, and we've had an overwhelming response in terms of questions that people want to know what we do and how we do it. So let's just dive right into it. One of the first questions, since we haven't done this in a little bit of time, that I think is really important is, what is occipital neuralgia? It's a common question. Obviously, it's a diagnosis that people haven't heard. But first of all, occipital just refers to the area in the back of the head. That's the occipital region. And neuralgia is a term that means nerve pain, okay? So when it comes to occipital neuralgia, the diagnosis refers to pain in the back of the head caused by a nerve. Now, there are three named or fairly large, relatively speaking, nerves in the back of the head. They are known as the greater, the lesser, and the third occipital nerve. The third occipital nerve is also sometimes referred to as the least occipital nerve or dorsal occipital nerve, depending on which paper and authors you read about. And these are the nerves that are typically thought to cause most of the symptoms when it comes to occipital neuralgia. So the question then becomes, well, if you can identify which nerve is causing the algia, in other words, which nerve is causing the pain, the question then becomes, what is making these nerves cause the pain? So these nerves are all sensory nerves, which is to say that they only provide sensation, in this case, to various areas of the back of the head. They do provide some sensation to the deeper soft tissues because they often have branches that go through those deeper soft tissues, but the majority is sensation to these areas in the back of the head. So they are not motor nerves. In other words, they don't move any muscles. And when they function normally, they provide sensations so that you can feel if somebody's rubbing, touching, tickling, poking the back of your head, etc. When they malfunction, those same sensory nerves actually cause a lot of pain. And so a lot of times the typical symptoms of occipital neuralgia are paroxysmal. It means kind of on and off shooting electrical-like pain in the back of the head, and it goes along the distribution of the nerve. So, for example, if you're talking about the greater occipital nerve, typically starts just off the midline, that's the center line in the back of the head, so to one side, and kind of radiating over the vertex of the skull. And that's the top point in your scalp. Now, that being said, just as all people are individuals, not everyone will have those exact same kinds of symptoms. And because everybody perceives their discomfort differently, everybody will have different types of symptoms. And so it's not necessary that you actually have shooting electrical-like type pain in a specific location in order to be diagnosed with occipital neuralgia. Sometimes people just feel a sharp stabbing pain in one area. Sometimes people feel a pulsating and pounding type of pain, and sometimes people just feel a lot of pressure or almost like a squeezing in one area. And that speaks to how people perceive pain, because at the end of the day, the discomfort from any cause is always a subjective thing. And so that is what occipital neuralgia is. Now, how do you make the diagnosis of occipital neuralgia? Well, in my mind, I have, as many of you know, if you've watched our prior Burning Migraines questions, if you followed us on Instagram or Facebook, on our Facebook page, if you've delved into our website, Pelid Migraine Surgery, which has a lot of information, a lot of blog posts that I encourage anyone interested to go peruse, because it has a lot of these things written down and in a form that you can access under our blog link. You know that I have a specific type of perspective on this, being a peripheral nerve surgeon. So what is a peripheral nerve surgeon? It's a surgeon that operates on the peripheral nervous system, and the nervous system can be divided in any number of ways, but one of the ways in which it can be divided is into central and peripheral. Obviously, the central nervous system is in the center of the body and has to do with basically the brain and spinal cord, and that's usually the purview of either the neurosurgeons, brain surgeons, or the orthopedic spine surgeons, okay? However, all of the nerves outside of the brain and spinal cord are part of the peripheral nervous system. They're out in the periphery. So those are all the nerves that go to your fingers and your toes and the belly button and the trunk and in the head and neck, but not necessarily inside the skull. But in all these muscles that we emote with when we scowl at our significant other or our kids, in these muscles that bulge when we chew and clench the back of our teeth, and of course in these super strong muscles that hold up these bowling balls we call our heads. And when these peripheral nerves in the head and neck, which take very circuitous routes from the spinal cord to their final destination in the skin, because they take such roundabout ways through all those soft tissues, when they are pinched or irritated, they send messages back to your brain, and and that causes pain, and you perceive that, and most people would call that a headache. Okay. And in principle, if you think about it, it's really no different than if you stepped on a tack with your big toe. I think most people would agree that the nerve endings at the end of the big toe are sending messages back to your brain and telling you, wow, my toe hurts. And so what do? You pull the tack out or move your foot away. And so occipital neuralgia, in my mind, is oftentimes a function of a mechanical compression or irritation of an occipital nerve, which then sends messages back to your brain and tells you I'm having head pain. And again, a lot of people call that a headache. So the diagnosis for occipital neuralgia in my hands really comes in the form of three factors or criteria that you have to meet. One, you have to have a good history for a pinched or irritated peripheral nerve in the head and neck, or nerves, because sometimes it's more than one nerve that's involved, causing your symptoms. And what that means is that you have already seen other types of doctors, such as your primary care physician, some form of headache specialist, anesthesia pain management physician, obviously a neurologist, and have ruled out other quote unquote more common causes of headaches. And I put that term most common in, or more common in quotes, because I think occipital neuralgia is actually much more common than we think. I think it's very underdiagnosed. But of course, you want to make sure that you don't have an aneurysm, that you don't have a brain tumor, that you don't have multiple sclerosis, that you haven't had a stroke we don't know about. And so if you've seen other physicians and you've ruled out those other causes, if you've tried and failed a lot of usually more than one class of headache medicines, if you have failed various conservative treatments such as massage, physical therapy, acupuncture, biofeedback, and if you have imaging studies such as an MRI or CAT scan of the brain, an MRI or CAT scan of the cervical spine, the spine of your neck, that shows you don't have an aneurysm or a brain tumor or a herniated disc pinching one of the nerve roots, then almost by default, you might have a mechanical compression or irritation of one of these occipital nerves more peripherally, meaning in the muscles in the back of the neck, and that may be amenable to the type of treatment that I provide. So criteria one, good history. Criteria two, you have to have a good physical exam that suggests you might have a pinched or irritated peripheral nerve in the head and neck causing your symptoms. And what that means is that if you were to come and see me and we were to examine you, do you have hyperesthesia, meaning hypersensitivity, or painful scalp to the touch? A lot of patients will say, for example, that their, quote, hair hurts even just to touch or to brush, or when the wind blows on it, or when they have it up in a ponytail, for example. So if you have those kinds of findings on a physical examination, and if you gently tap over where these nerves can potentially get pinched, and where we know based upon anatomic studies that they occasionally do get pinched, and you get an exacerbation of your symptoms when we tap over these areas, that's a sign, not 100% of course, but a good sign that there could be a nerve that's in trouble there. And so that would be criteria two, a good physical exam that suggests there could be a peripheral nerve problem. And the third criteria is that you have to have a good result with a nerve block. So let's define what a nerve block is. A nerve block is simply an injection of local anesthetic. It's like the, quote, Novocaine that you get when you go to the doctor. It temporarily and chemically inactivates a nerve. And if your pain is caused, at least in significant part, by an irritated, for example, greater occipital nerve, then chemically and temporarily inactivating that nerve should cause some decrease in your pain. And so, for example, if the patient were to come in and their pain were an 8 out of 10, and you were to block that nerve, and the pain almost immediately, which is to say within a few minutes, goes down to a 1 or a 2 or a 0, or even is cut in half, that is a successful result with a nerve block. And it suggests very strongly that that nerve, the greater occipital nerve in this case, is to account for some measure of that chronic pain, in this case, the chronic headache. So those are the three criteria that we use: good history, good physical exam, good result with a nerve block. And if you meet those criteria, then you will have a good, you are likely to be a candidate for surgery. And so if you have a good history, a good physical exam that suggests a peripheral nerve is a major cause or the cause for your chronic headache pain, and you have a good result with a nerve block, that means you are likely a good candidate for surgical intervention, which very grossly speaking, we've talked a lot about this in other forums that we can address in other burning migraine questions sessions in the future, but takes the form of a nerve decompression. In other words, there's pressure or some object like an enlarged blood vessel pressing on a nerve, and you can decompress that, meaning free that nerve up from that pressure. And in some cases, if the nerves are really badly damaged, you can cut them and bury them such that they essentially go to sleep, and hopefully you have relief of your pain as a result. All right, so going straight to some of the questions that we have had, which are really good questions, and one that's actually particularly relevant that I wanted to make sure that we covered is what is the sort of relationship between migraines or chronic headaches and long COVID? So first of all, let's define what long COVID is. Everybody knows what COVID is after 2020. It's something that's not likely to be forgotten anytime soon, but basically long COVID refers to symptoms that persist, usually for greater than 4 weeks, long since the acute symptoms of a COVID infection have resolved. So let's say you get, God forbid, an infection with COVID, and you have a cough and some shortness of breath and a fever, and after a few days or a week, that goes away. Many people are reporting some degree of long-term symptoms. And so, for example, there was a study of 180 non-hospitalized patients. So these are not people in the ICU who have a ventilator and a breathing tube and are in the prone position on their tummy just to try and stay alive. These are people walking around inside their homes, hopefully quarantining. And more than 50% of these patients reported still having at least one type of symptom that they didn't have before their COVID infection, an average of 125 days after their acute symptoms abated. So in other words, after the acute episode infection of COVID went away, more than 50% or about 50% of, actually it's more than 50% of patients still reported having their symptoms. And the second most common symptom, 68% of patients reported chronic headaches. There's a different survey of patients, another 177, of which 161 were not hospitalized, and about 19% of patients were reporting at least 3 or more symptoms that they didn't have before their acute COVID infections. 14% were reporting at least one symptom, and 29% said that they still were not at their baseline level of functioning many months after their COVID infection went away. And so the question now becomes, okay, if headache or chronic headache is a common sequelae or result of a COVID infection, what's the mechanism? What is going on and what can we do about it? Well, fortunately, very serious neurologic side effects from COVID are relatively uncommon. They're certainly less common than, for example, respiratory effects, difficulty breathing, shortness of breath. But there are two potential global ways to think about how COVID could affect the nervous system. There is a potential for direct nerve injury. And how would that occur? Well, we know that COVID invades certain blood vessels and specifically, or certain cells, specifically the cells that line our blood vessels through a specific receptor in the cell membrane. And when they do that, they can cause inflammation and basically plugging up of those little blood vessels. And of course, just like your fingertip has a blood supply, just like your liver has a blood supply, so do all of the nerves. And those nerves have very, very tiny, almost, in fact, many times microscopic blood vessels that feed them. And when they get plugged up, essentially, those nerves become what we call hypoxic. So that means there's lack of blood flow, which means lack of oxygen. And therefore, we all know that all cells need oxygen to survive. And of all the cells in your body, liver cells, kidney cells, bone cells, nerve cells are among the most sensitive to that hypoxic injury. And so if you have infection with COVID, and you have some direct injury to these microscopic blood vessels, your nerves are essentially choked off, and the neurons, the nerve cells within those nerves, which are bundles of neurons, could actually die. And obviously that can cause all sorts of symptoms depending on which nerves we're talking about. So that's one mechanism, direct nerve injury. Another mechanism that is thought to play a role in some of the long-term neurologic sequelae of COVID is an indirect injury. And so we know, for example, that COVID infection is associated with a pretty profound inflammatory response. Your body reacts to that invading organism by causing, in some cases, pretty severe inflammation. And when that occurs in the lungs, for example, it becomes hard to breathe. Well, one of the mechanisms that we believe causes occipital neuralgia is a mechanical compression on the nerve. And I will tell you that nerves normally pass through fairly tight spaces in the body. And so long as the nerve is of a certain size and the space is of a certain size, all is well with the world. And so, for example, if this was the carpal tunnel, which is a normal anatomic tunnel or canal at the wrist, and this was the size of the median nerve, which is the nerve that passes through the carpal tunnel and that becomes injured in carpal tunnel syndrome. So if the nerve is this big and the tunnel is this big, as the wrist flexes back and forth and moves up and down, all is well with the world as that nerve glides back and forth. If the tunnel narrows because of some kind of inflammatory process, COVID infection, arthritis, then that nerve is pinched. And as you move your wrist, instead of gliding back and forth, that nerve becomes kinked. And with repeated micro trauma that will occur when you try to move that nerve back and forth and it doesn't glide easily, you can imagine that you'll eventually develop scar tissue and pressure on that nerve. Similarly, if the nerve, which is normally this big, is now swollen and is this big and is trying to pass through that same space, it is effectively pinched. And certainly if both of those phenomena are present, the nerve is also quite compressed or pinched. And so there are two mechanisms, one direct, one indirect, in which COVID can affect the neurological system and cause chronic symptoms such as chronic headaches. And if you have an inflammatory process and therefore pressure on the nerve, that symptomatology may be amenable to the type of treatment we perform. I will certainly say I have not seen a patient with occipital neuralgia as a result of COVID infection as of yet. We may at some point see those types of patients. It's still very early on and we're still learning quite a lot. So the jury is still out as to the exact cause for the chronic headaches, for example, and patients who have long COVID. But please stay tuned. We will certainly keep you abreast of anything that we learn as time goes on. Now, we had a related question is, could occipital neuralgia be related with Lyme disease? And again, Lyme disease is a virus, much like COVID, and a different class of virus, of course, but it is a virus. And if the virus of COVID, SARS-CoV-2, can cause inflammation, so can the virus that causes Lyme disease. And so if you have a virus that in this case is known to affect nerves directly, such as the virus that causes Lyme disease, and those nerves become inflamed and they try to expand within the very fixed spaces in which they're located, you may have pressure on those nerves. And therefore, if we're talking about an occipital nerve that becomes inflamed, then yes, you could theoretically have a mechanical compression on the nerve, which would easily cause occipital neuralgia. Now, we've had a number of different questions about physical therapy and occipital neuralgia. And the question is, can physical therapy be good in the treatment or helpful in the treatment of occipital neuralgia? And of course, the answer is yes, it can. We said at the outset that the occipital nerves take very circuitous routes, meaning a kind of a roundabout way going from the spinal cord to the skin to supply the scalp and the back of the head. And those nerves, as a result, pass through many very thick and very strong muscles. So if those muscles are spastic or constantly clenched, they will continuously press or squeeze those nerves. And physical therapy can certainly help to correct any imbalances that patients might have that cause one side of your neck muscles to clench as opposed to the other side, to perhaps compensate for weakness on one side versus another. Massage as part of the physical therapy program can help to loosen those muscles. And so the idea there would be that the pressure or squeezing of the nerve would be decreased and the irritation of the nerve would be lessened and the symptoms would improve. We had a really interesting question. Who is the best person to see for occipital neuralgia and ongoing help? And I think that's a great question because it's not entirely clear for most patients and certainly most primary care physicians who even know what occipital neuralgia is. So I think the idea first is to recognize what occipital neuralgia is, again, a painful or irritated nerve that's causing pain, and then to try and use that background to try and figure out a cause. So there are a number of things, as we said, that you can do to try and treat occipital neuralgia. There are medicines that people have used. There are various injections that people can use. There are conservative treatment modalities such as acupuncture, massage, physical therapy that we've mentioned before. And so I think the best place to start is with your primary care physician to make the diagnosis. And if they are unsure or think that that's the case, but don't have enough familiarity with that, I think a referral to a neurologist is a really great place to start because the neurologist should be able to make that diagnosis, and B, try to figure out what is causing those occipital nerves to be irritated. Many neurologists are also trained to perform nerve blocks. And so those nerve blocks can be used to help with the pain that one might have with occipital neuralgia, and can certainly be useful, if nothing else, for diagnostic purposes. And neurologists are also really good at managing those types of symptoms with medications. And so if you have a medicine that is able to control your symptoms and to do so without side effects and very effectively, then managing your pain with medicines really works. I think when you have failed lots of different types of medicines, lots of different types of injections, when all else being equal, we in the medical community have been unable to find a cause, I think a referral to a peripheral nerve surgeon who might be able to block that specific nerve to temporarily get rid of your pain. And then if that's successful, potentially release that irritated nerve or treat that irritated nerve in some way. And that might give you a result that could be permanent and hopefully without any numbness. And then we had a couple of other questions that we can get to, and then we will save this long list of really great queries for the next time. This particular patient said, why does one side of your temple take longer than the other side to recover from surgery? And that's a really good question. And I think it gets to what is it that you actually do during surgery. So in the case of the auriculotemporal nerve, it's a nerve that comes out and goes to this part of the scalp and sometimes the top of the head, just at the helical root. That's where the ear meets the scalp, right around there. Sometimes a little forward, sometimes a little back, sometimes there are multiple branches. And that nerve often lies very close to fairly large and fairly powerful blood vessels, the superficial temporal artery and the superficial temporal veins. So during surgery, what you do is you expose that nerve, you make a little incision, you look at the nerve, you find it, you identify it, and there are either blood vessels, veins and or arteries, or fascial bands. These are little connective tissue bands that are compressing that nerve, usually against the underlying blood vessels, so that the blood vessel is pounding against that nerve, and because you have this really tight tissue above it, the nerve has nowhere to go. So a lot of times, not always, but a lot of times the people who have auriculotemporal neuralgia will actually report a kind of pulsating, pounding pain, and a lot of patients will press really hard there to try and basically compress those blood vessels to get them to stop pulsating. Oftentimes that does get rid of the pain, and because you're pressing fairly hard on a nerve can actually numb the nerve for a while. Pain gets a little bit better, and then as soon as you release that pressure, the blood starts to flow again, and the nerves become re-irritated, and sometimes the pain comes back even worse. So during surgery, the nerve is gently teased away from these compressing fascial or connective tissue bands, and usually the blood vessels of superficial temporal artery and veins are either cauterized or tied off and moved away from the nerve so that they no longer irritate it. Now, if you do that on both sides, and that's a very common thing to do because a lot of times patients will present with similar mirror image symptoms on the right and the left, you may have actually different anatomy on one side than the other. So on one side, there may be just one relatively small blood vessel that's compressing the nerve enough to cause symptoms, but just working on that one area frees the nerve up completely, and there's really no other issues. On the other side, you may have a blood vessel that is wrapped around the nerve, much like an anaconda will squeeze its prey by wrapping around it and squeezing it tightly. In that case, that blood vessel has to be teased away from the nerve in multiple locations. And the bottom line is that there is more manipulation of the nerve on one side versus another during the operation. And it also likely means that there's been more damage to the nerve on one side over time than on the other side. Both are symptomatic. Maybe one was more symptomatic than the other. It is also potentially possible that, and I see this all the time in my office, that patients have had symptoms on this side for 10 years, but it's only been in the last 2 to 3 years that the symptoms have really started on this side. So the duration of whatever pathology is present has been longer here than here. And so when you operate on those people, you may be actually doing more on one side than the other. And the symptoms may have been present, and the damage caused by those compressive structures may be more severe on one side. And that is very likely the reason, in most cases, why recovery of the nerve on one side can take a lot longer than on the other side. And then we have one question, which I think sort of ties things together here as a take-home message and a very positive thing to leave you with, is occipital neuralgia lifelong? And I think it used to be thought that that was the case. If you had it, we would try to basically manage your symptoms with medications or various injections from time to time, but it was thought to be a condition that you would have to struggle with forever. I can happily say that after operating on several hundred patients with neuralgia of various kinds, whether it's occipital or frontotemporal neuralgia, which I call trigeminal branch neuralgia, because the frontotemporal nerves are all branches of the trigeminal nerve. Many times, if you successfully decompress all of the nerves that are compressed and treat them appropriately, the symptoms do go away. And in a large number of patients, the symptoms are significantly better. And in a not insignificant number of patients, the symptoms completely disappear. And just as a last point, the 5-year follow-up data on these types of patients was actually published about 10 years ago. I think it was February 2011 or 2012. And what it showed was that 5 years after surgery, when all of the compressed nerves were adequately treated, 88% of patients were still reporting a minimum 50% reduction in frequency, severity, and or duration of pain. And about 1 out of 3, so 29% was the actual number of the study, were completely headache-free. And so the answer to the question is ON, or trigeminal branch neuralgia, a lifelong problem? The answer is no, not necessarily. It doesn't have to be. And so if you're not finding successful treatment with the more common therapies, such as medications or injections, I think an evaluation from a peripheral nerve surgeon trained to do these kinds of operations really makes a lot of sense. I will leave it there, and I want to thank everybody for joining in. I want to thank all of you for sending all these questions. I promise we will try to address them all over the next several weeks, as we're going to be doing more burning migraines questions videos. Please keep sending in your questions. If you see this on Facebook or Instagram, follow us, like us, whatever those terms are, and feel free to ask questions in the threads or feeds, and we'll try to get to them in subsequent episodes. Thanks, everybody. Hope you have a pain-free rest of your week. Bye-bye.